What is your name?
Name is Edward Allen Miller.
And in which city and country are you based?
I am based in Boston, Massachusetts, the United States of America.
Great. What organization do you work for?
I work for the University of Massachusetts, Boston, in the Gerontology Department and the Gerontology Institute. I'm also affiliated with Brown University and the Providence Veterans Affairs Administration Center.
Great. Okay. And how would you explain what you do to a layperson?
Primarily, I look into the determinants and effects of federal and state policies affecting vulnerable populations, in particular the frail and disabled elderly, the mentally ill, the urban underserved, and veterans.
Okay, great. And what is commonly understood as long-term care in the U.S.?
Long-term care is commonly understood as assistance with basic activities of daily living. So bathing, dressing, toileting, transferring from one place to the other, eating. But it's also known as well in relation to instrumental activities of daily living. So not such basic activities, but so more like, preparing meals, going shopping, cleaning your household. And it's a little bit different. We don't think, it is social care, but it's quite different from here, where there's that distinction between medical care and social care. The definition has really been broadened, so it's really those social care activities to involve people with their activities of daily living and instrumental activities of daily living, but also the funding source matters. So Medicare, which pays for post-acute care, that's often lumped in with long-term care as well, so sort of short-term rehab, post-hospitalization as well.
Okay, thanks. And what would you say are the main 3 policy priorities for long-term care in the U.S.?
Well, there's a difference between what should be a policy priority and what is actually going to happen. What needs to happen is, first and foremost, we need to address the financing dilemma. Right now we're very much based on a safety net type system where people basically expend their assets and life savings, their income, and once that happens, then after they've spent down, then they qualify for Medicaid, the joint federal state program for the poor, low income, elderly, and disabled. And so creating a system where people start from a younger age and save and think about their frailty and older ages, so is really a first step towards, the idea is more financial independence. The problem is going to be so large that there's no way that the government can take care of it all, and therefore we need to get people to either privately insure or save so that they have choices. And so that's really the second bit, is what are you going to have choices about? Is it going to be nursing home care? Is it going to be assisted living? Is it going to be home and community-based services? And not just for you as a potential care recipient, but also for your family, because your choices, we rely on them. Most people rely on long-term care, rely on unpaid informal caregivers, and so essentially, if you have a choice for home and community-based services, then you can help supplement and complement and relieve those who otherwise, need to work or otherwise be paying for care for free. And then I think the third part of it is you have financing, you have choice of services, but then what is the quality of those services going to be? We're sort of, quality is important, but thinking about what we mean by quality, do we mean about the structure of, or do we mean about process? Most measures are focused on process, and I think most fundamentally people want to focus on outcomes. But what outcomes? Do you mean quality of care? Do you mean quality of life? And I think we need to think more about quality of life. We need to think more about people having those choices, and so having choices within a certain care setting, whether it be at home or a nursing home, where they control as much of their daily life as possible, where the regulatory system and the accreditation systems, to the extent that they exist, the licensing systems sort of value that. I think that's really the third leg of the stool that you know, we need to focus on in our priorities.
Okay, interesting, very interesting. Thank you. To what extent do you think these priorities have changed over the last 5 to 10 years?
I think there's been so taking, say, financing at first, we haven't moved much on the financing front. We tried to with the CLASS Act, the Community Living Assistance and Supports Act, which was contained in the Affordable Care Act, the health reform, but because of the way the system was structured, it would have basically bankrupted itself. You know, they made it available for both younger disabled folks as well as older people planning for their frailty and older age, and the fact is adverse selection would have been a significant problem, and because it was going to be a self-financing system primarily through premiums, there was no way to sort of cross-subsidize it through other sources or general revenue. So essentially with financing, we're essentially at the same place we've been for a long time, which is essentially a system that relies on people paying out of pocket, and then maybe Medicare for a short while, but then ultimately relying on safety net, Medicaid. And actually that might change recently. Former President Clinton, in his speech before the Democratic National Convention that just met the other day, there's been a lot of sort of debate about what's going to happen to Medicare, but he also brought up that Medicaid, which people traditionally think is a welfare program, is increasingly used by the middle class to pay for nursing home care in their older years. And so in that respect, it's going to become, I think it may become a big issue in the campaign. In fact, on the front page of the New York Times today, there was an article about Medicaid and long-term care. So who knows, maybe we'll move in some direction beyond sort of the focus on private financing and trying to spur private financing, which we've made some efforts, but it just hasn't gone that far. In terms of choice and in terms of home and community-based services and options such as that, we've made quite a bit of progress in the U.S. Over the last 5 to 10 years. There are waivers from traditional Medicaid rules. Medicaid requires states to pay for nursing home care, but not necessarily most home and community-based services. However, states can seek waivers from the federal government, and they have in droves, and there's been a tremendous growth in the provision of home and community-based care. This was stimulated in part by a Supreme Court decision in 2000, which basically said if somebody can be cared for, people need to be cared for essentially in the least restrictive setting possible. So we've had basically decisions from the judiciary, as well as the executive branch in the federal government, and as well as among the states. The key problem here is that while some states have made tremendous progress, example, Oregon, Washington, where actually more is spent on home and community-based services than nursing homes, other states are far behind. So for example, Rhode Island is 89% nursing home expenditures on long-term care and Medicaid, and just 11% HCBS. So there's tremendous variation, and so there continues to be inequitable access across the country, and within, as well as within states and regions, say urban versus rural. There are more options in urban areas than there tend to be in rural areas, and so this sort of geographic equity issue needs to be addressed. And finally, in the third issue, in terms of quality, and when I'm talking about quality in terms of quality of life and choice, there's been a movement, the culture change movement, which over the last 10 years has really focused on changing nursing homes from the traditional focus on sort of hospital-like setting, schedules that are imposed on residents, kind of grew out of the medical model. There's a growing emphasis on creating facilities that are more home-like environments. There are examples such as the Eat an Alternative, which brings in pets and plants, to so what are called greenhouses, which are really small pods, as they say, within a broader organizational structure, but which essentially does away with the long corridors, creates a more home-like setting, gives people a choice about when they, say, wake up, they dine, what they eat. And I think there's been a greater emphasis on that, and that's reflected both in movement in the provider sector, in the advocacy sector, but also in the regulatory sector as well. And that's why, with the latest iteration of the survey and certification protocol that the federal government requires states to use, as well as with the minimum data set, which collects data on nursing home residents when they enter, and then on regular intervals thereafter. There's been increasing focus on quality of life and actually asking people about their life experiences within the facilities.
Okay, great summary, thank you. Do you get a sense that the financial crisis is having an impact on long-term care in the US?
Certainly. So part of the issue is the financial crisis has created problems both at the federal and state levels, but the federal government, unlike the states, can print money, can acquire debt, and has done so quite prolifically over the last 12 years. But the states have to balance their budgets. And so the federal government had the American Recovery and Reinvestment Act. That was 2009, one of Obama's first initiatives, over $700 billion, and essentially helped stem the tide towards depression, which we were headed towards as a country. Instead, we call it the Great Recession, not the Great Depression, Part 2. But a large part of that was tax cuts to support individuals, but another large part of it was to support state and local governments. And so what you saw was a lot of aid going to support Medicaid. I forget the exact amount, but I think it was like maybe $89 billion. It was one of the largest single chunks of the Stimulus Act. And what that did was provide states with enhanced federal support. So states are traditionally funded at 50 to 83%. So this added like at 4 to 6 percentage points or something like that to the federal match. And so that helped in several ways. It helped, so the states didn't have to spend money on Medicaid, and the roles, you got to think about it, people are losing their jobs, they need publicly provided insurance, so the rolls on Medicaid went up. People are poor, rolls on Medicaid are going up. And so states, on the one hand, need to spend more on Medicaid to care for people who are losing insurance. On the other hand, Medicaid is the largest portion of their budgets. It's 25% or more of most states' budgets. I think on average, maybe 21%. But it's a very large proportion of state budget. So if they're going to look for places to save money, it's going to be Medicaid. So the Federal Stimulus Act helped sort of ameliorate that for a while, but that expired. And since it's expired, states have let public workers go. The public workforce has shrunk, particularly at the state and local levels. That has hampered the state's ability to ensure, to administer the programs, to ensure the quality of care of their programs, including the quality of care delivered by Medicaid providers. In terms of funding, although there is an emphasis on expanding home and community-based services, and there are provisions within the health reform law, the Affordable Care Act, which was passed in 2010, to stimulate, incentivize states to expand HCBS, home and community-based services. A lot of states are actually cutting back on HCBS because they can. Because as I mentioned before, nursing facility care is a mandatory service. HCBS is an option. And so even though that's what the state governments believe, it's questionable, but they believe that moving people out of nursing homes into home and community-based services settings will save money, they're actually cutting back on that because they have the freedom to do so. And so I don't think they're taking up as much of the ACA sort of incentives and freedom to expand their home and community-based services as they would if it was not for the financial crisis. So I think those are probably the major ways that it's had an impact on states.
Again, great summary, thank you. If you had the opportunity to introduce one new policy reform, what would that be? Why? And why, sorry?
I mean, fundamentally, I think it has to be about financing. In some sense, financing provides the ability to make choices, and if you could, and to the extent that you can make choices as a frail and disabled individual, frequently coming out of the hospital, having to find a place to go, within a very quick period of time, at least your family or yourself. But if with a lack of preparation and a lack of financing, and with the federal budget deficits where they're at, where state deficits being a continuing problem and having to deal with that year after year, that there's going to be a significant challenge dealing with Medicare as the program for health insurance program for the elderly, which pays for post-acute skilled nursing facility care and home health services, and for Medicaid, which basically pays for those who spend down for long-term care services, long-term nursing home placement, and home community-based services. That the entitlement crisis and people's lack of preparation for particularly among the baby boomers, and it might even be too late for them, I think makes financing and dealing with the financing issue a significant area of concern. But it's not just providing financing to help people pay for the services and have choices, but it's also trying to maybe be more cost effective in the delivery of care. I mean, there's only a certain amount of money that we have to go around. We might be able to draw some additional revenues in, but we can only do so much, and so we want to use those dollars more wisely. So I think I would sort of pull in the cost effectiveness aspect as part of the financing issue, and so making sure people are prepared and spending the public dollar most efficiently is probably where we need to go.
Great. I'm going to ask you 4 quick-fire questions.
Sure.
What I want from you is a number. So on a scale between 1 and 10, 1 being poor, 10 being good, could you tell me what policy priority is allocated to long-term care in the U.S.?
2.
How aware is the general public of what the long-term care system offers them?
1.
How well does the system support people with long-term care needs?
3.
And how well does it support their carers?
1.
Thanks very much, Eddie.
Sure. Happy to do this.